Okay, hello everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. For those of you who have been in our community for a while, you know my obsession about brain health, really understanding the latest science on brain health, what we can do today to improve our brain health and prevent dementia. So today we're going to talk about cholesterol. Admittedly, I'm quite confused on the topic, good versus bad cholesterol, how we monitor it all, and really what we need to keep in check to maintain brain health. So we've invited with us Dr. Gregory Jicha. He is from the University of Kentucky and an expert on this topic. Greg, thanks so much for joining us.
Sure, I'm delighted. Thank you so much for having me. And we'll see what we can chat about today.
Well, I'm sure you're going to have a lot to add to this conversation, but let me just take it down to the very basics. Let's just start with cholesterol because, the more I read, the more I get confused kind of on what's good, what's bad, how we tell the difference, how we process cholesterol. So how does the average person, aside from taking a blood test, how do we know really where our levels should be and what we should be monitoring?
Yeah, this is really important. Let me take it back even one step further and say, what the heck is cholesterol and why the heck do we have it? And why is it essential for the brain in the right levels and concentration? That's really, really important. Every cell in the body, especially the nerve cells in the brain, have a coating around them, a membrane that holds the cell together. And that membrane is made out of different kinds of fats in our diet. And so if those membranes were made out of pure or saturated fats like bacon grease, well, our nerve cells would congeal like bacon grease in a pan. So instead, we need the unsaturated fats that make that membrane smooth so that nerve cells can reach out and form new connections. But there are parts of the membrane that have to be a little stiffer to hold things together. And cholesterol plays a vital role there, mixing with those fats to make sure that nerve cells can be dynamic and we can learn new things when we need to learn new things, but also not just a complete blob in general. So
Is that when we hear the term saturated and, unsaturated? I get very confused around that. Is there, everyone's like, go for the avocados, go for that type of fat, coconut, is there, in terms of brain health, a difference between the types of fats that we should be ingesting?
Yeah, there is. And we really should be going for the unsaturated fats. If we think of the saturated fats, they're so saturated and full of fattiness that they congeal like bacon. But the unsaturated, so polyunsaturated fatty acids, PUFA, this is what we see in many of the olive oils, in fish oil, in these oils that are good and healthy for the brain, allowing the brain to have that fluidity that it needs, balanced with an appropriate amount of cholesterol.
So is it a bit, though, like maintaining a balance? So does it depend on how healthy we are in terms of how we process these fats and therefore our brains benefit? Is that the right way to think of this?
So there's certainly healthy lifestyles can help regulate cholesterol, but a lot of the fats really come from our diets. So the best way to regulate your cholesterol health and fat health, as well as brain health, is really to modify the diet. That's where you're going to be most effective. And so we see things like recommendations for the Mediterranean or the MIND diet. And when we talk Mediterranean diet, we're not talking falafel and couscous, right? right? We're talking rich in vegetables, olive oils rather than saturated fatty oils, nuts and fish and things that are brain healthy in general. And a lot of that does indeed have to do with the fat content and the different types of fats and cholesterol found in those foods.
So what is the direct link between cholesterol and Alzheimer's disease?
So this is interesting, and it's kind of a long story scientifically. We've long known that cholesterol is important for heart disease and for risk of stroke, and so that's really kind of where the cholesterol story started. And we began to look at populations in the world that come down with dementia or those that may be at lower risk for dementia, and looking at those factors. And cholesterol is one of them that pops up in those studies, that people that have maintained a good cholesterol over time seem to have a lower risk of dementia. Now, that's a pure observation. They may be doing other things that are quite healthy as well, but it's a strong enough of an observation for us to understand. And now a lot of the new thinking is, if it's good for your heart, it's good for your brain. And that's a simple way for us to remember things like cholesterol, exercise, prevent heart disease, prevent wear and tear on the brain.
Right. But is there a way to describe it? So, for example, glucose, we know that glucose has a direct connection to our brain health in terms of brain function. Do we know yet, really? I mean, I get what's good for the heart is good for the brain, but do we know, like, biologically speaking, what is happening inside our bodies to our brains if we do tend to have a higher cholesterol?
Right. So the cholesterol trafficking in the brain, because as we spoke about earlier, we need the right amount of the right cholesterol, is carried by different cholesterol transporters, kind of the little shuttles that move the cholesterol back and forth. And some of those cholesterol shuttles are actually risk factors, genetic risk factors for Alzheimer's disease. So one that many people may have heard about is called ApoE, or apolipoprotein E. It's a cholesterol trafficking protein, and mutations in this that prevent the appropriate cholesterol shuttling clearly lead to a massive increase in risk for Alzheimer's disease. So there's indeed some direct evidence, and ApoE influences, along with bad cholesterol, influences a risk not just for Alzheimer's, but a biochemical risk for the development of the amyloid plaques that build up in the brain of someone with Alzheimer's disease. A lot of this comes from scientific experiments in the laboratory, experiments with animal models of disease, but the human data seems to parallel that.
Right. So, okay. And we're getting a question. Kim is asking, can HDL be too high? Now, let's first back up and explain, because, all of us who get blood tests, we're like, HDL, LDL, what's the difference? Which one should I look at? So maybe you could just explain the difference between LDL and HDL when we look at the results of our blood tests.
Right. Very, very important. This goes back, to age-old debates in medicine over which is better, which is worse. We typically consider HDL, which is high-density lipoproteins, as being your good cholesterol, and LDL's low-density lipoprotein. So the H and the L stand for high and for low. And that doesn't mean high levels in terms of number. It's the density of cholesterol that they can traffic. So an HDL is considered a good cholesterol for you, and your LDL is considered your bad cholesterol. And so for many, the American Heart Association really hones in on that LDL. It's the bad cholesterol that we want to keep low, 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 low. Now, that could be offset by having an extremely high HDL. And then we can accept a little bit more of the bad because the HDL is protecting. The best cholesterol would be a very high HDL and a very low LDL. That's
what are those ranges? Like when we look at the results of the blood test, what ranges should we be in? Is there such a thing or is it individualized?
So typically the ranges will vary. Sometimes they even vary by the laboratory that you're in individually. And a lot of this is still somewhat debatable. And it's something that I always marvel at. For the average person walking down the road, if we're looking at their LDL, their bad cholesterol, how low should that level be? Then typically we're saying we would like your level below 130. But if you've ever had a heart attack or a stroke, we want it below 100. But if you're a diabetic, we want it below 70. So we have 3 different numbers for what a good cholesterol is. I look at that data and I say the best cholesterol level for a low density lipoprotein in LDL is below 70. That is the most protective against chronic health conditions, including possibly the risk for Alzheimer's disease.
So now everyone's going to go and look at their latest reports, make sure that's under 70. But as Kim pointed out earlier, can HDL ever be too high? Or it sounds like it can't, right?
Not from what we know. HDL can not be too high, and it's really is that ratio. So the HDL will contribute to your total cholesterol. And if all it was total cholesterol, HDL would be as bad as LDL because it's total cholesterol. And so we look at the two differentially so that we can understand if someone's cholesterol is high, is it high because the HDL is up or is it high because the LDL is up? And again, keep that bad cholesterol down.
Okay, that's really helpful. Thank you for that. The next thing is triglycerides. Like we all see, I have a family member who has particularly high triglycerides. What are triglycerides and how are they related to that heart-brain health?
Right. So triglycerides are very, very important of that test that your doctor sends you for. It's not just cholesterol, HDL, and LDL. Excuse me, but triglycerides are included in that as well. Triglycerides are a different type of fat. And a lot of what we see in terms of bacon grease congealing is due to triglyceride content. And so many foods are very, very high in triglycerides. And triglycerides, like cholesterol, can be good or bad. So coconut oil, we've heard about coconut oil as potentially being good for the brain and good potentially for Alzheimer's disease prevention or treatment. And that is a triglyceride. It's a medium chain triglyceride that can serve as a fuel source for the brain. But too much bad triglyceride, again, what happens is the brain starts to congeal and it can no longer perform its functions. It's very injurious, and as well as increasing risk for stroke and vascular disease. And sometimes, we've talked about in the past, many people are familiar with the term hardening of the arteries. That's when the tiny blood vessels just start pinching off one at a time. Never a stroke, but slow damage. And that slow vascular damage is also interrelated with Alzheimer's disease. And much of this can be driven by triglyceride levels. So
you mentioned 2 different types of triglycerides, but the last I remember when I looked at my blood report, it just said triglycerides. There weren't 2 levels like HDL and LDL. So how do we know what types of triglycerides are being read, and what does it mean if you're kind of off the charts triglyceride level? Like, is that a big red marker?
So you're right, and we don't break down the triglycerides. There's special laboratory testing that can be done, but much of the free triglycerides that are rolling around in your bloodstream are really of the bad type. They're overwhelmingly the bad type. And there are families, as well as you've commented on, there are families that have a genetic form of high triglyceride levels, and very, very important to keep our eye on those triglycerides as well. And so this debate in the field, over cholesterol, is it HDL, is it LDL, is it triglycerides? Well, it's all of them, and they need to be in the right amounts each. And so we have a variety of different medicines that we use, some to treat, some that might elevate HDL if it's too low, some that might lower LDL if it's too high, and others that affect the triglycerides. And working with your doctor and those numbers from the laboratory test, you may be placed on different medicines to try to regulate your cholesterol levels to prevent those downstream harmful effects.
Okay, and that brings us to the next topic, which is a lot of what your research has touched on. Can we use medications like statins to actually reduce the risks to our brains? I mean, obviously, pop a statin, your cholesterol levels go down if you have elevated cholesterols. But what does this all mean for our brains? And what do we know in terms of using these types of medications to actually reduce the risk brought on by bad cholesterol inside our brains?
Great questions, and really, really important, because at the end of the day, understanding the science is not half as good as preventing the downstream disease. And of course, we're all afraid of diseases like Alzheimer's. So cholesterol, as I've said, has long been linked to the development of dementia. And so as statins began to become used for lowering LDL and increasing HDL, there were observations that people on these medicines in different populations of the world across multiple countries would have a lower risk of developing dementia, probably through those mechanisms that we talked about, reducing amyloid plaques, reducing vascular disease, and the like. So we've actually tested statins in multiple clinical trials, and we have yet to come up with convincing evidence. So the population data suggests, but this is something that we absolutely need to do, and yet the clinical trials. And so we puzzled over this, and there are really two explanations. One explanation is when you're put on a statin to lower your cholesterol to prevent stroke or a heart attack, we know that the benefit is not seen until several years out. You've got to be on them for a significant period of time. When we do clinical trials, we're typically doing them for 12 months, 18 months, and it may not be long enough of an exposure to statins to begin to see the benefit. So that's one possible explanation. A second possible explanation that's been toyed with is that maybe it's not the LDL or the HDL. Maybe it may be more related to the triglycerides, and maybe we need to use different medicines. And so that's a thought that came about really about 20, 25 years ago. Several studies came out of Europe showing this benefit of being on cholesterol and triglyceride lowering medicines. And there are a few of those studies, Tri-City study in France and Italy, that actually looked at this and reported that the benefit may be much more related to the triglyceride effect of different medicines rather than the HDL or LDL component. So
what are those, I'm sorry, I don't mean to interrupt. What are those medications referred to? I mean, we have statins that tackle the cholesterol. What are the medications people use for triglycerides?
So typically we consider these fibrates, and the fibrates have been with us for a lot longer than the statins. and are still widely used, especially for those that may have a better control of their HDL, LDL, but still have high triglycerides. They may need a statin and a fibrate in combination. Those that have normal cholesterol but abnormal triglycerides just need a fibrate. And so the medicines are used interchangeably for our cardiovascular health.
And your research looked at the link between taking these fibrates and the reduction of risk for dementia. Is that correct?
So that's correct. What we've really known about these, and the data from those European studies suggests that if you have ever been on a fibrate in your life, your risk for Alzheimer's disease is reduced by about 60%. Now, that's pretty darn good,
That's a huge reduction.
Yeah, that would take our 6 million people with Alzheimer's in the United States and bring it down to 2.5, sparing 3.5 million people. That would be incredible.
But can we look at that in the reverse, that really elevated triglycerides are a huge risk factor for dementia? Can we reverse that?
So we're looking at this currently. And so we kind of got into triglycerides, because we're interested in this whole, relationship. But also it came in from a side angle from us. We were looking at something called microRNAs. These are tiny little pieces, kind of what people used to think was DNA and RNA junk. It doesn't really do anything. It's just little fragments and pieces. But the Nobel Prize was actually awarded, I believe, in 2007 for the discovery of these microRNAs. So it's not that long, just a decade and a half or so that we've known about these. They're important regulators of health and disease. And we found a microRNA that began to decrease years before you develop Alzheimer's disease. And when we looked at that microRNA, we found that it was produced right in the middle of a protein that is upregulated by fibrates. So fibrates upregulate proteins that fix your triglycerides, but also influence and increase this microRNA. The microRNA has direct effects on suppressing Alzheimer proteins. So we looked at it in two ways. We said, well, we're going to fix you metabolically by helping your triglycerides. Simultaneously, we have a direct effect potentially on the production of amyloid plaques in your brain. So this may be a double-edged sword. We may be able to get in there and get double the bang for our buck.
So does everybody have these microRNAs? Is that
absolutely everybody has these? They can be too low. This microRNA can be too low, and if it's too low, then we have a problem. So the goal of our study really was to use fibrates to increase that microRNA level, shut down Alzheimer's disease, and improve your metabolic health through reduction of your triglycerides.
So, like you said, fibrates have been around for a while now, right? And so, is this the first time we're linking those drugs to the prevention of Alzheimer's disease, or is there some sort of scientific research historically?
Now, the research historically has largely been observational and in animals. So to date, the study that we completed just a few years ago was the first study in humans of using fibrates to directly examine brain health. They've been looked at for prevention of stroke. They've been looked at for prevention of heart attacks. This was the first to look at prevention of Alzheimer's disease as a result of fibrate therapy.
And what about, I never can remember this name, the fat drug that everyone's injecting to lose weight. Is it semaglutide or something? Yes,
semaglutide.
Semaglutide.
Yes, So there's a few of these. These are new agents that originally developed for diabetes, type 2 diabetes, that can reduce insulin resistance and restore metabolic health. So the semaglutide story as well is quite interesting because we've long known that metabolic health is a direct influencer of Alzheimer's disease. Well, there are now millions of people on semaglutide across the globe for their diabetes, and we're starting to see, well, those that are on semaglutide are not coming down with Alzheimer's disease. So this may be another way to influence the brain's metabolic health and shut down those Alzheimer pathways.
Well, we have a question. So, so we now understand the influence or the link and the positive impact that fibrates can have on the brain. So, Kim is asking it. So, should everyone just be on fibrates?
So, that's a very good question. Right now, we have our preliminary data. The study that we did was a relatively small study, 74 people, 36 to 38 in each group. And with that, we saw very directional changes in everything. We saw microRNA 107 increase. We saw amyloid decrease in its production. We saw benefits in memory and thinking.
So, were these people who already had plaque in their brains and MCI?
These were people at the very early stages. Some people who were normal and already had the early buildup of amyloid, some with MCI. They were not patients with full-blown Alzheimer's. We think that fibrates will probably work best in the prevention of disease. So what we found in the study was not only a correction of the Alzheimer abnormalities, but a dramatic improvement in the metabolic health of the brain, including hardening of the arteries. So now we think, again, we have our first human support for this, but we need to do a bigger study. We estimate that we need to do a study of 400 people to definitively prove the fibrates may be helpful. And we're working on developing that study and getting the funding for it right now.
Okay, well, thank you so much. And we should add, obviously, we're not telling everyone to go out and take these medications because you need to consult your doctor and figure out what's best for you. And obviously, there's still a lot of research that needs to be done before we can have make conclusive statements about that relationship between fibrates and the prevention of Alzheimer's. But the early research does look promising. So thank you so much, Dr. Greg Jicha, for coming on Being Patient and sharing your knowledge. We look forward to the results of your next study and research. I'm passionate about the brain health. I do think that more funding needs to go into brain health research so people like you and me can learn how science is telling us to prevent Alzheimer's disease. How do people keep abreast of your research?
So people can always look at the University of Kentucky website and look up my name. I work at the Sanders Brown Center on Aging, and we're all about healthy brain aging and prevention and cures for Alzheimer's disease. So the website has a host of information. We have a YouTube channel with many of the scientific talks because we hear a lot in the media, and sometimes we really need to break that down and understand what's fact, what's fiction, and what's just being hyped without any real science behind it. So I appreciate what you do here, Deborah.
Thank you. And absolutely, I was going to say the reason why we started Being Patient. So thank you so much for sharing your knowledge. If anyone has missed any of this interview, don't forget to go to beingpatient.com. We'll repost this interview or our YouTube channel. And we'll also include the link to the University of Kentucky where Dr. Jicha is so that you can explore for yourself more information, great information that they have on brain health. Thanks so much for joining us, and we'll see you soon.